joining. So let's go ahead and get started. WHCRMS is excited to host this educational session on decisional capacity. A little reminder, after today's session, all attendees will receive a post-attendance survey. This must be completed in order to obtain your continuing educational credit. During the presentation, please feel free to type questions into the chat box, which will be addressed at the end of the presentation during the Q&A portion. I'm honored to introduce Dr. Danielle Kaiser. She is a highly respected and experienced board-certified psychiatrist with the Peace Health Healthcare System, where she currently serves as the Northwest Network Medical Director for Behavioral Health and the Medical Director for Inpatient Behavioral Health Sciences at St. Joseph Medical Center in Bellingham, Washington. Dr. Kaiser, I will now turn the presentation over to you.
Unmuting would be helpful. Thank you. I really enjoy giving this. We'll wait for that to go away.
It just reminds us how much we're all balancing at once, and that we really appreciate your time.
Well, and unfortunately, I can't mute that, so hopefully it doesn't happen again. Anyway, this is a talk I really like to give, and mostly because it's not a long presentation, and it leaves a lot of time at the end for questions and discussions. And so it's different every time. I started giving this talk before I started working for Peace Health, so it was probably about 2006-ish. And I started giving the talk. I went to University of Washington, where they have a really strong ethics department. And I did my residency there, and I did a geriatrics fellowship. As part of my training, I learned to do a decisional capacity evaluation. And when I got out of residency, and I'm just going to talk over her. When I got out of residency and I was in my first job, it became clear to me that not everyone learns how to do a decisional capacity evaluation. A lot of physicians just kind of wing it.
Here? Oh yeah, because there was a button.
Oh, okay, good. Anyway, so I started giving this this talk back then and have modified it a little bit along the way. Let's see if we can. There we go. So this talk is about decisional capacity, which is a clinical term. Competence, I'll often get a consult to go see a patient, and someone wants me to just determine that they're globally incompetent. The law is actually not clear on the difference between competence and decisional capacity. When I read different pieces of the law, it's kind of contradicts itself, but for our purposes and for our clinical purposes, competence is not something that a physician can determine. It's a legal definition, something that is adjudicated by the court. As we as physicians don't determine competence, we determine capacity. And so we're going to use those terms like that during this talk. And like capacity, incompetence can be temporary. You know, for instance, you cannot be competent to drive a car, but you can go to some classes and you can become competent to drive a car. As a medical professional, we determine decisional capacity. This is the medical term, like I said, and it's related to a person's ability to rationally make decisions regarding their health care. When we're determining capacity, we must appreciate that there is a tension between the patient's autonomy, their right to make their own decisions, and sometimes their well-being that we need to balance. This is the most important slide in the whole talk. If I didn't do anything else, this is the only slide I would show you. And sometimes this is the only slide I send to people. Because these are the 4 components that I use when determining decisional capacity. I sent out, and you can all get, hopefully from Sarah, There's a longer form called the aid to capacity evaluation, which really just takes these 4 points and breaks them out into some more detail if you're having difficulty determining if someone has capacity or not. But these are really the 4 main points. First of all, they must be able to communicate a choice. Someone who's in a coma and can't tell you what they want, they don't have capacity. Secondly, they need to understand the underlying medical issue. And we're going to go through these 4 points in a little bit more detail, but basically, we don't expect them to be physicians, but we do expect them to basically understand in layman's terms what is going on with them. They need to have the ability to discuss the pros and cons of treatment, including the option of no treatment and what that means. And they need to form a reasoned decision consistent with their underlying values. And the reason I put reasoned in italics is it is not always reasonable to us, especially as physicians. Sometimes the decisions made are, in our view, a poor decision and doesn't seem reasonable. But if it is reasoned out in that patient's mind, in the context of their life and their values, then it's valid. We apply the standard more strictly for procedures with more risk and potentially less benefit, like a complicated cardiac surgery, and less strictly for procedures with less risk but higher yield, like IV fluids. Typically physicians don't even get, informed consent for IV fluids. They just, hang them because the yield is high, the risk is super low. Capacity can be determined by any doctor. It's best determined by the specialist seeking consent. And I say that because I often get asked to come and see a patient, again, about that complicated cardiac procedure, and I don't understand the procedure myself. So the person who's trying to seek consent can answer questions and is best able to seek that consent. If they really need my help in doing it, I often have to take them with me, so that we can talk to the patient together and make sure that they've gotten all the information they need to make an informed decision. Okay, so we're going to go through those 4 points on the important slide here in a little bit more detail. So they're kind of basic. So case number 1 is a 30-year-old man. He arrives in the ED comatose. He doesn't have capacity because he can't communicate his choice. And we're going to get a little more complicated. Case number 2 is an 87-year-old woman with dementia. She has a ruptured appendix. She's refusing surgical intervention. When interviewed by multiple staff members, she cannot remember that she has a ruptured appendix. So does she have capacity? She does not, and she falls apart kind of in point 2. She can communicate her choice. She doesn't understand the nature of her illness because of her dementia. Case number 3 is a case from my training in Harborview. It was, a 42-year-old man with schizophrenia. He refuses IV antibiotics for his infection. He does not understand why he can't just take a pill. He's frustrated and wants to leave the hospital. He does not want these antibiotics IV. Does he have capacity? In my view, we don't have enough information in this case to say whether he has capacity or not. He was able to communicate his choice. He knew he had an infection, so he understood the nature of his illness. This gentleman had inadequate informed consent. He didn't understand that his particular infection could not be treated with an oral medication. It had to be treated with an IV medication. And once he had that teaching, he was willing to do the IV antibiotics. So he was competent, but he was not well informed in the whole informed consent process. So what is valid consent? You have to have adequate information. there has to be the absence of coercion, and you have to have decision-making capacity. In my work on the ethics committee, we talk about these topics quite a bit. And coercion can come from various sources, family members who want a patient to press on when they're wanting to transition to comfort care. Sometimes the provider really wants the patient to receive treatment and kind of is pressuring. But valid consent should have no coercion, adequate information, and of course capacity. So we've got case 4. Case 4 is a 25-year-old woman, and she refuses blood as part of her surgical procedure, and she's a Jehovah's Witness. Does she have capacity? Again, I don't think we have enough information in just this little brief case description. But looking at our 4 important points, she is able to communicate her choice. She understands the nature of her illness. She can discuss the risks and benefits of the proposed interventions. And she is able to manipulate the information and make a reasoned decision based on her longstanding beliefs. So while that surgeon may feel uncomfortable with her decision because they may not see it as appropriate for the surgical procedure she's undergoing, this is her right to make this decision. Similar case number 5 is a 25-year-old woman with schizophrenia. She refuses blood as part of her surgical procedure. She believes receiving the blood of another person will allow that person to take over her mind and body forever. So does she have capacity? We look at our 4 points. She's able to communicate her choice. She understands the nature of her condition. She can even discuss the risks and benefits of the proposed intervention, but she can't rationally manipulate the information to form a well-reasoned decision because her decision is influenced by psychosis, by something that we can hopefully treat and then help her make an informed decision. If you can't decide, if you don't have decisional capacity, who decides for you? We're lucky in Washington that the law clearly outlines who gets to make the decisions if you can't make your own decision. And not all states are this clear, and so we're very lucky to live in this one. And this is the hierarchy in order of importance. A legal guardian will trump the durable power of attorney for healthcare if one is available. If we don't have a guardian or an identified durable power of attorney for healthcare, and it's important to look at those documents because we often get people saying that they're the power of attorney. We get the documents and they're for finances or something else. They're not for their healthcare. And people don't always understand that they didn't sign over power of attorney for everything. If we don't have either one of those more official folks, then we look to next of kin. And the law in Washington also gives us a hierarchy for these. Their spouse or registered domestic partner is first, adult child, a parent, then an adult sibling. And the law was amended in 2019 to include a few more folks, and adult grandchildren are next, who are familiar with the patient. Adult nieces and nephews who are familiar with the patient, adults, aunts and uncles who are familiar with the patient. I don't know why they were chosen in this order. Or any adult who has exhibited special care and concern for the patient, is familiar with the patient's values, is reasonably available to make the healthcare decisions, and will provide a declaration demonstrating they meet criteria. They are also not allowed to be a physician of the patient, an employee of the patient's physician, an owner or administrator of the facility where the patient resides. So it has to be, a friend essentially, but and not a professional individual who's providing healthcare. What do they decide? How do they decide? The best standard to use when you're making a decision for somebody else is a standard we call substituted judgment. And that is what would the patient have wanted if they could have made the decision. We attempt to respect their autonomy by using substituted judgment, by respecting their previously held and expressed wishes. But sometimes we don't know. Sometimes we have become a power of attorney for someone and we really haven't had those deep conversations about what to do in what situation, or the situation comes up that we hadn't discussed, because all sorts of things happen. In that case, then we're supposed to use the best interest standard. And that's what is best for the patient, but it's judged by the surrogate, which has its own problems. It addresses the question of what makes life worth living, which may be different from person to person to person. What I consider a good quality of life is not necessarily what the next person considers a good quality of life. So the best interest standard is challenging. On the ethics committee and on the palliative care team, they try very hard when using surrogate decision makers to not say, what do you want us to do? But to phrase things so that, and to have a conversation with a surrogate decision maker to figure out would this patient have chosen to our best of our ability to figure out based on their previous choices, based on what they previously said, and not putting all of that on the surrogate decision maker to be responsible for these life and death decisions. But really trying to draw out as best they can what the patient would have wanted based on those things. Sometimes we end up talking with all sorts of people around an individual. One person who was we called unbefriended. He didn't have any people around him except for his bartender at a local bar. And that was the only person we had to talk to about his wishes. And we did talk to her to try to find out, who he was and what decisions he might want to make in these situations, because we just had nothing to go on. And then this is shamelessly borrowed from some other physicians who give lots of decisional capacity talks and, kind of wrote the book, so to speak. Our 10 myths about decisional capacity. And I won't read through these, but I will leave them up while we have a discussion. We have apparently a lot of participants today, so let's start answering some questions.
So Danielle, or Dr. Kaiser, sorry, we got some questions in the chat that I'll read. If people prefer to ask their questions, go ahead and put up your hand and I will call on you after I get through the chat messages. Okay. So the first one is, competence can be decided by any doctor. Is this more like a provider, physician's assistants in clinic and or ER? The better you know the patient, I think the better you are at determining decisional capacity. So I'm speaking to the ER here for a moment. Meeting the patient one time, you can often determine the decisional capacity, but it is better with someone who knows you longer. So like your primary care provider who may have known you for years, I think will have a more accurate assessment than someone who just met you once. And it also depends on the situation. When I've had to testify in guardianship proceedings, the court usually likes it to be a physician. But it doesn't, in my view, it doesn't have to be a physician. And I ask my social workers their opinions all the time. Because they, have maybe had a conversation with that patient about something that we're doing, amputation of a leg, let's say, and what that means for their life. They may have had more of a conversation about that than I'm able to have. So I gather all that information when I'm making my decision. So I think, the opinions of the folks around the primary physician are very important. But the court, if they are involved, they typically want it to be a physician. How can a practitioner ensure an absence of coercion in an acutely symptomatic patient? And this question, I believe, came up when you were talking about patients with mental health disorders.
It's challenging. Again, that one-time evaluation is often, not the very best for making these decisions. Knowing the patient, knowing how they might be coerced, gathering the information from, the team around you, if you can, to try to figure it out. Sometimes I'm sure we're making mistakes with the whole coercion piece. And I can think of some of our ethics cases of, an elderly individual with lots of family who's making a decision. And then, you find out 3 days later that behind the scenes, the kids are coming in the room and really pressuring mom to make one decision versus another. And it's not until mom is comfortable with her treatment team that she says, hey, I really don't want to do this. I really want to do something else. And so it is something that I think is best determined over time with a lot of information.
Tracy Harris, you put a question in the chat box, but also raised your hand. So if you want to ask your question, the floor is yours.
I will. Can you hear me okay?
Yes.
Okay, great. So thanks for the topic, important topic. My background is in hospital-based medicine in a critical access hospital. So not a ton of great access to other folks that can weigh in on some of these issues. And I think one of the things our institution struggles with the most is our geriatric population with some degree of cognitive impairment, mild, moderate, or severe when it comes to long-term living situations. So I wondered if you could comment on that a little bit about how and if somebody with, I'll say at least the question was moderate dementia, can ever have decision-making capacity and some strategies that you might use over time to try to address that.
Yeah. And this is something that we come upon a lot. You can have capacity to make one decision and not another decision. We really determine this on a decision to decision basis. It's not something that we determine globally. And I say that because that person with cognitive impairment can probably make simple decisions, like taking an antibiotic for their urinary tract infection. And one thing that comes up a lot is, can they sign paperwork to designate a power of attorney? I find that folks can have the capacity to make that decision pretty far into their dementia, because it's a concept that is really familiar to them, that's kind of pervasive out there in our society, what it means, that someone else is going to make your decisions when you can't make them for you. It's not incredibly complex, and it's something that people are familiar with. Whereas that same person might not be able to make the decision about that complicated cardiac surgery because they may not have the cognitive capacity anymore to manipulate the information. I think, one of the places I get consulted a lot is, does someone have capacity to make the decision to refuse to go to assisted living or a nursing home, or they're trying to go home and we know that they can't manage there. And I think that's part of your question.
For sure, part of the question.
And they think that they can manage. So if you were just to go through those 4 points, they would have capacity because they tell you they want to go home. They would tell you they understand that home could be dangerous, but they've mitigated it with all these things, and they're able to cook and they're able to clean and they're able to do all these things, when actually they're not. And so in those cases, I have occupational therapy or speech therapy do some cognitive testing, do some living skills evaluation, and run them through their paces and see, can they really do what they thought they could do, and have them help me recommend a level of care. And that is a decision that's fairly complicated and really emotional for so many of our elder folks who don't want to lose their independence. But yeah, that's where I call in a friend, and usually it's the occupational therapist.
And maybe if you could take that a little further, and then I promise I'll shut up and let other people have the opportunity here. My sense is this is probably a fairly common
Yeah,
issue.
it is.
Yeah. So take that a little bit further. Perhaps the care team has determined, wow, this person really doesn't have the ability to make this a rational, reasonable decision. And we start to go down the pathway of decision makers. Most commonly, folks don't have a guardian. There may or may not be a power of attorney. There may or may not be family. Could you speak to that a little bit? That same list that you gave, guardian, power of attorney, family members, in exactly that situation. Mom, grandma lacks decision-making capacity, needs higher level of care. At that point, can spouse, family, et cetera, without a formal power of attorney, essentially place that patient or get them to a different assisted living facility, et cetera, truly against their will?
That's variable on, and it seems to be community to community based. I have been in communities where that spouse can sign that person into an assisted living facility, and they have, alarm bands on the wrists or locked doors, and the person can't leave, and that's okay. There are other communities where the facilities won't accept someone if they're going to try to leave. And, even though someone else signed you in and they may have the legal authority to do so, they may not have the physical ability to keep that person safe in the facility, so they won't accept them. So even our guardians, even folks that have nobody, and so the hospital goes ahead and applies for a professional guardian for someone. In some settings, they can't sign someone in against their will because no one can keep them there. So that's a question that I think the answer we have to figure out individually kind of every time based on the situation.
And when you say communities, do you mean communities even within Washington State, or are you talking about outside Washington State?
Both. Yeah. Because someone may have the legal authority to do something, but still the accepting facility has to accept that it is their practice or their policy to take the patient.
I'm going to have another follow-up question, but I'll shush until others get an opportunity to finish.
Okay, I am going to skip over one question in the chat box from Sharon Hall and go back to it, only because another question was put in here related to this topic, and just to keep us on there. But I'll ask, I'm not sure if what you said answered this. For patients who are stable for discharge, are we able to use surrogate decision makers within the hierarchy to accept placement if a guardian or DPOA is not in place, or is this only for informed consent about care? Also, are SNFs and adult family homes able to use surrogate decision maker instead of requiring DPOA? We have several individuals who are non-decisional. However, the next care setting is requiring a DPOA before accepting the patient. I think that's what you just touched on too.
Yeah, and that's exactly, I think, a great example of the law says this next of kin can make the decision, but the facility isn't going to accept that because they are requiring, their policy requires a DPOA. And so we do get stuck quite often on this tension between law says we can do it, but the practice of the facilities is not the same.
Okay. If a patient is over the legal alcohol limit but seems to meet the 4 capacity elements, is it appropriate to assume competency and proceed with letting the intoxicated patient provide their own consent?
Oh, that's a good one. I don't think anyone's ever asked me that one. I think it would depend to me on the emergent nature of what we're trying to get consent for. Let's say this was an intoxicated person in a car accident, and not operating right away is going to put their life in danger. In those situations, we don't always even obtain consent in a big emergency. So it would be a bonus if the patient could provide some sort of consent in that situation. If you have time, it's always best to have them sober up. And that would be my advice is, let them sober up, but in an emergency, you might not have time to do it.
Okay, and I think that is all the questions that were in chat right now. And Nobody else has their hand up. Tracy's hand is still up. I know it sounds like she had another question. So if you want, we can go back to Tracy's question. And again, crowd, please feel free to type questions in the chat box or, raise your hand. This is designed to be an interactive discussion.
Yeah, and if you have cases to discuss, I think those are always the best because, I put those 4 points up. It seems really simple. There are these 4 things that you got to worry about, and but it's always more subtle than that. And there's so many different situations that make it more challenging than it looks like to decide capacity.
Well, Tracy, if you
I was trying to give the 7-second pause to let other people chime in. I didn't want to usurp this. And it's around sort of the same topics, and I could describe a case, but it's ridiculously complex. The general question, maybe it's still around decision-making capacity, still around who can make decisions when others cannot. And I wonder if your institution or if you've heard about others utilizing the ITA pathway for some patients in particular with major neurocognitive impairment, kind of through an ITA pathway, not seeking psychiatric care, but ultimately seeking a least restrictive alternative that may include memory care.
Yes, so I'm going to back up and speak more generally, and then remind me if I don't get to the memory care part. I'm a psychiatrist, and so I often am asked for someone who has delirium, dementia, or mental illness. And we've got a patient right now, of course, probably more than one, who is refusing medical care and trying to leave the facility. And they want me to come and get that patient detained on an involuntary psych hold so that either they don't leave the facility, or we can get them to do what we want them to do, or provide medical care we need to provide. The problem with that ask is that RCW 7105, which is the mental health law, allows me to hold the patient for psychiatric treatment. It doesn't allow me to hold the patient for medical treatment. It doesn't allow me to force medical treatment. I still have to go through this other process, maybe get a guardian, all those things that we already discussed if I'm going to provide medical care. It allows me to force antipsychotics. It allows me to force, certain psychiatric treatments. So it doesn't always serve the purpose that the person is asking me to come and take care of by putting them on a psych hold. Similarly, we can write anything we want into a less restrictive order or a less restrictive alternative. Different parts of the state call them different things. We can put all sorts of stuff in that document, but it doesn't really have any teeth. Because if the court puts in that document, you must go live here, put in the name of your assisted living facility there. What happens if the patient doesn't go and live there? Or what happens when they walk away? The only consequence is that you could be brought back into the hospital, have that less restrictive alternative revoked, and be brought back into the hospital. Why? For psychiatric treatment. It's not, people want to use it like you're gonna like a court order that you're gonna go to jail if you use alcohol again, or if you use methamphetamines or whatever. And it really doesn't have those kind of teeth. About years ago, I was asked to do this a lot, and I said exactly that. I'm like, write anything you want in the order, it's fine. If you think it's going to be helpful, but there's really no consequence to violating the order. Does that make sense?
Yeah, I think so. I think in my mind, maybe the larger question to be asked really is what are the mechanisms within the state of Washington in a very good faith effort? Please don't misunderstand this as trying to force somebody to do what they don't want to do, but in a very good faith effort to try to keep an individual safe, in particular where there aren't other decision makers. And it truly is that. Who's clearly unable to take care of themselves and lacks decision-making capacity and insight to understand why whatever their plan may be isn't a safe option for them. The mechanisms within the state of Washington to sort of do that, quote, against their will. And I hate that phrase, against their will, but in contrary to what an individual believes to be the best thing for them.
Yeah. Yeah.
And what I have understood for over the years is that there are very few ways in Washington State, and the ITA process is really one of the only ways.
Yes, but again, the ITA process is built for psychiatric treatment, and I found that is also different depending on where you are in the state, what the court will allow. And what the court will tolerate in terms of, someone's dangerousness, someone's ability to care for themselves. When I was in training down in Seattle, oh man, they let everybody go from court. If you could go into a dumpster and find a piece of rotten chicken, you weren't gravely disabled,
Sure.
Which is very different in Whatcom County. Where grave disability, they really do more carefully weigh whether the patient's actually safe and what they're choosing to do, to not eat that rotten chicken, so to speak. In our institution, in those situations where people don't have anybody, we do try to apply for guardianship. And again, the guardian is depending on what we're trying to get the guardian to decide for the patient. We've had various levels of success in getting folks placed.
It's been my experience too with guardians, is that guardians are variably comfortable making decisions for the patient, and will often try to be a patient advocate.
Yes,
which is appropriate, obviously is appropriate, but the hard part is if the advocacy is back to that same perhaps living situation that wasn't so safe that brought them in.
Yeah, definitely.
I gave my 7-second pause maybe for Tracy, but question in the chat. Can you describe any scenarios when a provider did not support the decisional capacity of an adolescent who is permitted by law to make healthcare decisions for self without parental involvement, and therefore the patient was not allowed to make the decision? What would be some examples? What could bring question to the adolescent's decisional capacity?
So this is a complicated question. And I am not an attorney. Some of this is kind of outside the scope of the talk, which is really how do we decide decisional capacity? In Washington, the law says when you're 13, you own your own decision-making regarding mental health, substance abuse treatment, and your reproductive rights. So it gets sticky, especially around mental health treatment, because, here you are, you got a 13-year-old and they're in the emergency department for a mental health crisis. The parents, of course, want this person to do certain things, most likely get treatment, most likely go to the hospital, and the person who is, considered their own decision maker at that point, says no. And we all know how well developed our cognitive abilities are for some of these things at 13. So you can imagine the tensions that arise. So if we're talking about a mental health situation, we do have RCW 7105, that we still can get that patient who we don't think has capacity to make their mental health treatment decisions. That person can be detained on an involuntary mental health hold, hospitalized, and treated. I'm a geriatrician, so this is going to get murkier and murkier for me as I talk. There is also something in the law in Washington called parent-initiated treatment, where a parent can basically hospitalize one of these kiddos. However, the parent-initiated treatment doesn't allow them to make certain decisions, like about antipsychotic medications and that. So the parent-initiated treatment process is really limited, from my understanding, on what can then be forced upon the adolescent if they are hospitalized. And a lot of the adolescent treatment facilities prefer that we get someone full-on detained on an involuntary hold before they take the patient, rather than take them under the parent-initiated treatment. I reached out to one of our child and adolescent psychiatrists in my community just to say, how do you handle this kind of stuff for, someone who, is 13, they own their own decisions for mental health care, but you don't feel like they really understand what they're deciding, even if they're agreeing with you. You don't feel like they understand. They really don't have informed consent about making that medication decision or another decision. And so what the practice is locally is to involve both the patient, the kid, and the parent in those critical decisions, so that it's really understood that that both parties are involved in the discussion. Because that's, it's a difficult time in life. I don't think, and we know our frontal lobes aren't fully developed at that point. And so we're not necessarily making great decisions during this time. In terms of forcing care when let's say the patient and the parent disagree, legally we can't force the care at that point. If it's a mental health, substance abuse, or reproductive rights issue. And frankly, not living in that world, I don't know how folks negotiate that. That was a complex question. Did I touch on all the points?
I think you did.
Okay. Anyone else have experience with that they want to talk about?
Okay, well, I think this next question is related to what was being discussed, prompted by Tracy's questions.
Okay.
Where or how do you hold the patient until there's a guardian?
And that's another question that is determined by institutional policy. Whether you can hold someone against their will, not on a psych hold, because maybe they don't have a psychiatric issue. Maybe this is just, chronic dementia that we can't treat. And again, a psych hold is for psychiatric treatment, not just to hold them. So some institutions I have worked with have, a 2-physician hold policy, that if 2 physicians determine that the patient doesn't have capacity and allowing them to leave is going to result in imminent harm, that they hold the patient in the hospital while trying to get an emergency guardian. Some won't. Some let them walk out the door, and knowing that that they may harm themselves, they may run in front of a car. But those institutions feel like there is a legal risk there that we can't basically illegally incarcerate somebody. And so that question is determined by each facility differently, and it's complicated, and it's really frustrating for providers. I encounter that all the time in the hospital. This last place I worked did this, and this other place I worked does that. And I talked to my friend over there, and they do this other thing at their facility. But it's something you got to determine for your own organization.
And it sounds like it's probably very important that your providers, your risk management team, your legal team, everybody's working together at each institution to make sure that there's a good understanding of the institutional policies and procedures.
Yes,
Okay.
definitely. And, and I frankly, I involve risk management in so many care conferences and we're really quick to pull a care conference together when something looks like it's not going well, and involve risk management, the treatment team, maybe ethics, and everyone sit down at the table and talk it out and make sure. I mean, it's hard to find all the different policies that might pertain to your situation. So having experts who know the policies at the table to help you negotiate that is really helpful.
Just Sorry, some things came in the chat. If a patient is demented and aggressive, can use meds and even 4-point hold to treat this without an ITA hold.
This is another, I think, facility by facility situation. The law in Washington is pretty clear about the fact that to force antipsychotic medications, we need to have the patient on a hold. We need to have a second concurring opinion that the medications, we try to obtain informed consent, and that we need to provide the medications to prevent further deterioration or prevent lengthening of the hospitalization or various things. But it's not entirely clear whether that pertains to folks with dementia, delirium, and we're not detaining every single delirious patient in the intensive care unit who is getting some Haldol because they're out of their minds with delirium and they need that medication to help them calm down and glue their thoughts back together. So this is another kind of institution by institution difference. In those situations, I think it's really important to have a surrogate decision maker and have a surrogate decision maker understand and agree with what you're doing. Even if the patient's accepting of the antipsychotic medication, there is, there are black box warnings around the use of those medications in the folks with dementia, and we use them all the time. But it's important for their surrogate decision maker to understand the risks and benefits. And if they're helpful, I've never had somebody say, no, don't give my mom that medication. But if they're not helpful, we also want to stop them right away. And the surrogate decision maker needs to understand that there are risks involved.
Okay.
Did that answer that question? And I've been at institutions where, yes, they'll put them in restraints to keep them from leaving or to keep them from hitting people. And I've been in folks in institutions where they won't, and they let the patient walk out the door.
Okay, next question. It's actually an adverse event in Washington to discharge a person unable to make decisions to other than authorized person. What might
Yes.
qualify as an authorized person? The top to bottom list of decision makers?
I don't know what that means. I've read that. I've read that a number of times, and I've even brought it up in conversations with administration when I don't agree with their decision. And no one has ever been able to tell me who is that authorized person? It's probably a parent, but is it a child? Is it a administrator of an assisted living facility? Yeah, it's interesting. Does anyone else have experience with that? Sounds like nobody knows what an authorized person is. And I've always been at a loss at how to define that.
One person commented could be a guardian.
Well, that is probably very true. But then what does discharge, what's the language? Discharge their custody or to the care? Because the guardian isn't going to probably take care of them, isn't probably going to have them at their house. So yeah, it's an interesting, interesting definition or I guess requirement.
The original question asker said, I've always just thought it was a responsible individual. And Christy, you just put your hand up. Feel free to ask your question.
I was just going to say that the adverse event guide that comes from the NQF, their glossary says that authorized means the guardian or other individuals having the legally recognized ability to consent on behalf of a minor or incapacitated individual, or the person designated by the surrogate to release or consent for the patient.
Thank you for sharing that. So based on that definition, the hierarchy would apply. Somebody just commented in the chat.
Yeah, okay. I believe so.
We have a few more minutes if anyone else has any questions or just comments, or as Dr. Kaiser said, any case studies, that you wanted to share. Looks like we did just get another question. Can a physician in Washington State legally relinquish and an ITA hold if the clinical situation has changed without going back to court?
Yes. And there's actually no paperwork to even be submitted to drop holds in most cases. Sometimes we have to vacate the orders depending on what kind of order and depending on what county you're in, which ones they require that the orders be vacated. But if someone's like on a 120-hour hold, the law is also very clear that they don't want patients held in the hospital longer than they need to be. And once they're treated to the extent that we need to treat them so they're safe to leave the hospital, we can release them early.
Can you comment on best practices regarding documenting decisional capacity and provider notes?
So I basically go through I walk through my thought process in my note, and I touch on all those 4 points in that one slide. That the patient is telling me this, they clearly understand that they have whatever, and they're able to discuss the risks and benefits of whatever treatments, and why I think they're making a reasoned decision. By writing it all out like that, it also helps me organize it in my own mind. Sometimes I leave a room and I can't tell you what my opinion is as to whether they have capacity or not. And it's really in the process of writing it all out and thinking about it in detail and explaining it so hopefully somebody else down the road can understand my thought process, that it starts to become clear to me what I really think about it. There are lots of cases, and I didn't talk about this earlier, there are lots of cases that seem pretty gray. And sometimes I'll leave and I'll think, geez, I know this patient can make a decision about, that antibiotic or that IV fluid, but I just am not sure they really understand this cardiac surgery. And in those cases, I often recommend that they have one of the folks from the hierarchy of decision makers with them, and that we consent both, kind of like they do with the kids. That we consent them together so that we make sure that if the patient isn't fully on board, that their surrogate decision maker is also there helping them decide. And that happens quite a bit.
Is there a standard form or EHR format to document your decisional workup, especially for the clinician who may not do this frequently?
Sarah, I sent you the aid and capacity evaluation, right? It was a couple weeks ago.
Yes.
Okay, if you could, can you send that out to everybody?
We'll send that with the slides.
Okay, awesome. There is a form, I think it's from the University of Toronto, developed this form that you can use kind of as a worksheet. And I could see developing a standard dot phrase or whatever in your EMR that would have all these points in. We don't have anything in my institution. I just freehand it every single time. And so, but it would be easy to do, I think.
Okay. Can you take the slides back to the 4 points? Got a request for that.
Another thing we didn't talk about is that you may not have decisional capacity today, and you could have it tomorrow. There's lots of folks that are delirious, and they're delirious because they have whatever medical condition, they got urinary tract infection or pneumonia or whatever. We expect that they will improve, and hopefully they will regain their capacity. It's also interesting when I read power of attorney documents, that sometimes they come into effect immediately upon signature, And some clearly say that they are not in effect until the patient has documented incapacity to make their decisions. So that's another important thing about, reading those documents and not just saying, taking someone's word for the fact that they've got power of attorney, because we don't always know what that means. We don't know what the documents say. So in the case of the person with pneumonia who doesn't have capacity and has a document that says, should I become incapacitated? Well, that surrogate decision maker can make those decisions during that time, but if the patient regains their capacity, they make their own decisions again.
It sounds like in cases like that, it would be really important even for the frontline staff to understand some basics about capacity. Then that way they know to trigger, perhaps a patient's capacity needs to be reevaluated.
Mm-hmm. Yes.
Okay. Well, as of right now, there's no more questions. Like I said, we will be sending out the slides and that aid capacity evaluation tool, and the recording will be on the WHCRMS website for members to review. Dr. Kaiser, I guess without any more questions, if you want to close up, and then I'll hand it over to Michael to do some closing comments. Okay, I really appreciate that you gave us this time today, Dr. Kaiser. Thank you.
It's a pleasure. And if there are any more questions, get them to Sarah. It's an interesting topic and lots of subtleties to discuss.
Well, thank you so much, Dr. Kaiser. Really appreciate it. It was a great presentation and such a relevant topic for all of our membership. So thank you very much. Just want to send out a quick reminder for our members who attended today to send out or to fill out the survey that will be sent to you by email. That should be coming here in the next hour or so. We will, as Sarah said, we will send out the PowerPoint and post the video to our website and our membership section. So it will be available to be viewed later. A couple of really brief WHCRMS announcements. Be on the lookout for some emails that will be headed your way pretty soon. We're going to be holding a social event in late March at Purple in Seattle. We'd love to get as much attendance at that as we can. So please, when we send out that email, what we're going to do is probably put in a little poll in there just to test some dates for people to try to see when we can get the highest level of participation for our members. We're also going to try to squeeze in another education session this spring prior to our annual conference. So be on the lookout for that. And if you have any ideas or if there's anything else that our membership wants to hear about, we'd love to know. The board really wants good interaction with the membership. And so if there's anything, any ideas you have, feel free to email them. You can email them to admin@whrms.com. And you can also go on our website under the education or membership section and fill out the form there. It sends us all an email for your topic. The annual conference will be in early June, and it will be in person, and we will also have a virtual option as well. And it will be at the WHAC again in Seattle. And you'll be getting a save the date for that here, hopefully in the next month or so, once we get all some of the details finalized. But we're really looking forward to getting back in person and seeing everybody's faces live, as many people as can, and as many people as are as comfortable attending. Thank you, everybody, again for attending today. Really appreciate it. Dr. Kaiser, thank you so much for your time, and have a wonderful rest of your week.